Chandak sir, please show them the nail first. So nail has a multi-locking system. To mic that anna sir anna. To mic protect.
So this is the nail. As you can see, on the tip, that is the part which would go into the shaft, there are two holes, and one of them is a dynamic hole. The tip is like our routine interlocking nail. The distal part has the routine bend, and as you can see, the locking can happen in different ways. The beauty of this nail is to give you a multi-axial stability. So there is an oblique screw. This is the only screw which needs some trick to pass. So you have not to go into the posterior part. And another beautiful thing is the head of this gets locked. So also this also screw gets locked. So giving you a length stable screw fixation. So this screw would not back out. So this is the main advantage of this multi-lock. So you have two screws which you can pass. There are multiple holes. Usually we would pass 3 screws. So 2 into one axis and one at right angle to the other axis. So that gives you a multi-lock fixation. What is our desire? Our desire is there should be a length stable fixation, one. Second, should give us a rotational stability. And that is the ability. So if you have around 5 to 10 centimeters in distal femur, that is a good place where you can put this nail.
Sure.
Yeah. So that means the screw has to penetrate through.
Yes. So you are having a pre screw size. So this is the threaded part, and the proximal part also is threaded. These threads are coarser than the routine threads. So lock onto.
So this is the position of the patient. So thoda light band kar. Thoda light band kar. You can see this is the position of the patient, and these are the CR images. Now the position is 45 to 50 degree flexion at the knee joint, and you can keep a bloster. So what is more important is now to identify this junction, domestic line, and this is the surface marking. You can see a tibial tendon. This is the upper part. ये parapatellar incision, para-tendinous incision. Mostly I give a trans-tendinous incision, and then with this, then we dilate this thing and pass a guide wire. Now this is the most important step. It is a 3 mm guide wire. Show sir guide wire.
Long enough to still remain out. Even the guide wire is long enough. Even if it comes out to the proximal part, goes to the proximal part, it would not go and go sinking into the bone. So you have still remaining part, and this is not much, because if there is a very long guide wire, threading this becomes so difficult. And on this you pass a hand rimmer. Initially remit for it. So whatever dust falls into the joint, you just get it out from a hollow gutter. You can bring it out, wash it, lavage it. After this initial core you have removed. Also another instrument which helps you out in this is a half cheese butter cannula of the distal femur nailing. So that also helps. You can core it out posteriorly half, then anterior half. That makes a good entry point. After that is your reaming. So then you take a reamer. You have ensured that it is sleeve protected. And the ligamentum patelli. What I like here is a good sort of a sleeve which can be specially made for this, so that you are not hurting the cartilage, not hurting the soft tissue.
So now we have to mount the nail, and first is the nail is mounted and then it is inserted inside. Now before that you must reduce the fracture. You cannot pass a nail in an unreduced fracture. You can take a help of a towel clip, and if you are very much aware, not able to do, you give a very small incision and then coax the two fragments and then pass the nail. Without reduction, don't pass the nail because it will go anteriorly, posteriorly, sometimes medial and lateral. And then when the part is made by nail, it will be difficult to correct the deformity. So this is how it is. After passing the nail, then you do two medial-lateral locking, and then we have to do, there is a separate jig for a oblique locking, and there is a lateral and medial this jig is there, and you can see here how you have to pass in nail. Generally it is your medial-lateral screws are 65 to 70.
Stop and go is the best technique whenever you pass a screw. So this is the part where it is coming out. Just to visualize, which can also be checked onto CR. You can palpate it also, and you also get the feel. So 3 ways you can check it out.
Is there any way to compress the fracture or you don't compress the fracture?
You can compress it, you can have a dynamic locking also. Compress means you have to just push it, and then you do a proximal locking. And this is not a distal locking, but you compress the fracture. But in a comminuted fracture, you just cannot compress it, it will produce shortening. So in that case, you have to maintain the leg. In a transverse and oblique fracture, you need to compress. And in that case, what you do first proximal locking, and then sunk the nail inside the condyle, and then you can with the blows, and then you can do the distal locking or condylar locking.
So for that we can also use technique what we call as a rock and roll. So one person holds the thigh firmly, the other person holds the zig, and you hold the thigh and then just rock whatever amount of thumping you can do manually. That is possible. It would not completely close the gap, but it would approximate the fracture better. Anything else you want to?
So this is actually it's a wonderful nail, and the jig is exactly matching it. There is only one that the screws are very interesting. You can see here the screw has a locking mechanism. So they lock in the shaft of the this nail also, and there is a locking here in the cortical bone also. The loosening of the at the cortical, if the cylindrical screws are used like a DHA, PFL, of a two screw system, they open. This cannot open. Therefore, it gives a very rigid fixation. And it's there are two screws are there, one mediolateral two and two oblique. And now in addition to this, there is another screw now, anterior-posterior screw. But there is a trick to pass an anterior-posterior screw because you will go into the popliteal fossa unnecessarily. So therefore, when you drill it, what you should do, you should have a drill machine just for this thing. So that near about 40 to 45 millimeter. Otherwise, what will happen? It will go into drill it. There is always a difficulty. So that this should be here. So that by mistake also it will not go into the popliteal fossa. This is the most important thing. And this is a wonderful technique. I have done number of cases. That does not mean that you cannot get a non-linear or breakage of screw or so many other complications. But it is a minimal invasive surgery which can be performed in a comminuted fracture, transverse fracture, even an oblique fracture. But they should be reducible fracture. And if at all you are not able to reduce it, better give a small incision, clamp the fracture, and then you do a intramedullary nailing. So this is how it is, a wonderful technique. And here, if you up to date 30, you have a jig for locking. So you need not do a freehand technique. But if you use a more than 35, then it is a freehand technique. So mostly now, previously we thought that the supracondylar fracture is here, we can use a 25-30 nail. But now with the recent literature, it is said it must reach to the lesser trochanter. So now the supracondylar nail of any variety, it should be near about 35 to 40 because there is only gap of 5 years millimeter. Therefore, it should reach here. Is it right, sir?
Yes.
so that stress riser effect should not
So longer the nail, better it is the concept.
concept. And you must lock in a both direction, AP as well as in the lateral. Suppose if you only use a lateral locking, what will happen? There is a unilateral translation, and then you get unstable construct. So this is a wonderful technique. Anything you want to ask, you
For
can.
longer nail, as you have mentioned, does it hamper the go of the femur?
No, it is actually, this is not. This is also it has a curvature. This nail has a very smart curvature. It's not that like a PFN long, but it is.
Some patients you do find a posterior opening a bit. So anteriorly if it is 2 mm, posteriorly you will find 3 mm or 4 mm. So femur